Hello, Texas Ombudsman. My name is Patty Ducaille, and I am your state long-term care ombudsman. Thank you for your advocacy efforts in nursing homes and assisted livings. Your tenacity to uphold resident rights and to protect the health and safety of residents is absolutely critical to giving residents the care and quality of life they deserve. Your presence in their lives and in long-term care facilities means so much. As a certified ombudsman, you know that the Older Americans Act authorizes the Ombudsman Program and requires each state to ensure an ombudsman has access to residents and facilities. In Texas, we accomplish this access by laws and rules that require facilities to allow our entry and private visitation with residents. Not only do we need access to residents, we also need access to information about them. This information, whether shared orally by a caregiver, the resident, or physician, or documented in the resident's clinical record, is all confidential. Remember, an ombudsman is required by law to protect a resident's confidentiality. Never share information about a resident without the resident's consent. We are lucky enough to have Dr. Schindler-Trochta to give us an overview of the basic contents of a medical record. Although you won't likely need to review a medical record in its entirety, Dr. Schindler-Trochta will give you a sense of what you can expect to find in a record from front to back. You should have a couple of handouts to follow along with the presentation. One is a set of PowerPoint slides. The other is a list of common medical abbreviations. I'll see you in a few minutes.
Hello, my name is Dr. Rita Schindler-Trochta, and it is my privilege to be able to speak to you about medical records. I am board certified in family medicine. Today, I will be discussing with you how to read medical notes, which will include a brief overview of commonly used medical acronyms, and then a fairly detailed look at how to use a medical chart, including its general organization and what information is included where. The purpose of this discussion is to aid you as the ombudsman in supporting the individual you serve, really who we all serve. After all, that's why we are all here, to do our role to help other people. So let's begin. I have in front of me a list of commonly used abbreviations. This list is also available through the Ombudsman Office. Let me mention that when a person goes to medical school, their vocabulary increases by over 10,000 new words. I want to assure you that you do not have to learn all 10,000 new words. I will point out some of the most commonly used abbreviations. BM equals bowel movement. That's an easy one because it's used commonly as well. But based on the context, BM can also mean bone marrow or black male. Similarly, CVA can have a double meaning. It can mean cerebrovascular accident, a stroke, or it can mean costovertebral angle, which is a specific area of the body. FU means follow-up. GI is gastrointestinal. IM is intramuscular, a route we use sometimes for medications. IV is intravenous. LLE is left lower extremity, while LLL is left lower lobe and refers to that area of the lung. LLQ is left lower quadrant and refers to the abdomen. LUE is left upper extremity. LUL, left upper lobe, again in the lung. And LUQ is left upper quadrant of the abdomen. N and V is nausea and vomiting. OT is occupational therapy. PE is physical exam. POD is postoperative day. Q means every, and little d is day, so QD equals every day. QID means 4 times a day, Sub-Q means subcutaneous, and VS is vital signs. Here are a few more. Little a with the line across the top of the letter is before. Little p with the line across its top is after. Little c with a line across the top is with. Little s with a line across the top is without. Little hs is at bedtime. Little ac with a line across the top is before meals. And PRN is as needed. There are even books available on just the topic of medical terminology and abbreviations, but I hope these are enough to get you started. So now let's turn to the medical chart and how we can use the chart to get information needed to support individuals we are serving. Today, I will be stepping you through a medical chart, discussing its purpose, where to find the chart, and what types of charts exist, and the overall organization of the chart. Let's get started. First of all, why even read a medical chart? Because you, as ombudsman, can gather information about your client in order to help them. The purpose of the medical chart is to facilitate communication between all people involved in a person's care. The physician uses the chart to review information, document his or her findings called progress notes, and write physician orders to direct care. The doctor is the person who is legally responsible for the care of the patient, but many people participate in care of the patient. Nurses, social workers, therapists, nurses' aides, and everyone has a place in the chart where they write information. So I will be identifying in more detail where to find information that you, as ombudsman, may find important in supporting the residents you are assisting. So where do you go to find the medical chart? A medical chart is located any place a person receives care. So you can find a medical chart in a medical office, in a hospital, and in a care facility in which they live. State laws govern medical records such as their accessibility and their retention. Federal laws govern the privacy of medical records. In nursing facilities, the medical charts are usually very easily locatable and are most often found at the nurse's station. There are several types of medical charts. Medical charts are usually found in a binder labeled with the patient's name and room number and are still usually a paper chart. There are a few facilities which have electronic records, and some facilities with a mixed bag or combination record, meaning a portion of the record may be electronic and a portion may be paper. The medical chart is usually organized into the following general sections and usually has tabs in the chart to identify the sections. Looking at the list of sections, you will note that there are tabs for administration, history and physical, vital signs, physician progress notes, and the list goes on. I will be discussing each of these sections in detail. Within the administrative section, you will find the patient demographics. Look in this area to find out the client's personal information, such as date of birth, family contacts, and the name of the primary physician. Near this section, and sometimes in the very front of the chart as you open it up, you should find the advance directives. The advance directives identify the type of medical care the person wishes to have in the event of a medical emergency. There are several types of advance directives, including out-of-hospital directives, who the person has designated to make medical decisions for them in the event they are unable to do so for themselves, and directives about whether they want artificial life sustainment procedures, such as feeding tubes or be hooked up to a mechanical ventilation machine. The history and physical section, called the H&P, contains summary information of all the relevant past medical history, past surgical history, allergies, and social history. It can also contain a list of medications, but be aware that the list of medications in the history and physical was valid for that day only. I'll discuss later where to find the current medication list. The H&P is the place for you to find out that Mr. Jones is an 88-year-old gentleman with a past medical history of diabetes, hypertension, coronary artery disease, and prostate cancer. He has had numerous operations for complications from his diabetes, including surgical removal of gangrenous toes, a coronary stent placed after his last heart attack, and a seeding procedure to treat his prostate cancer. He is widowed, no children, and was found in squalid conditions in his home prior to his placement in this facility. I recommend you start here in the history and physical section of the chart when you are getting yourself familiar with the case. The vital signs, as its title implies, is where you can find the latest documented patient measurements of temperature, blood pressure, heart rate, respiration rate, pain assessments, and other measurements such as ins and outs. The ins and outs, also written as the I/O, is the total volume of fluid and food and the total volume of anything that comes out of the body, such as urine, stool, or vomit. Yes, this is graphic, but bear in mind it is all important to people who are caring medically for the patient. The Physician Progress Note section is where you can find when the doctor's last visit to the patient was and what the medical findings and medical plan were as of that date. A physician's progress note follows a general template called the SOAP note. SOAP stand for subjective, objective, assessment, and plan. In the S, or subjective area, are items that have been subjectively reported to the physician, such as patient reports pain in sides, states vomited 3 times overnight and unable to tolerate any intake that is solid, reports nausea, no fevers, chills, or dysuria, or nursing reports patient was agitated overnight. O is for objective, is what the physician can measure or evaluate by physical exam. GEN is for general, and it is the physician's general observation of the patient. For example, general, alert and oriented times 3, which means the person is awake, alert, and knows their name, the date, and where they are. NAD equals no apparent distress. VS stands for vital signs, which in this example are reported as temperature equals 99.5, heart rate equals 95, respiratory rate equals 18, blood pressure equals 166/95. Next is the cardiac examination listed as cardio equals regular rate and rhythm without murmur, then lungs clear to auscultation, abdomen slightly tender to palpation at left lower quadrant. Next, on to the physical measurements such as laboratory results. UA equals urine analysis, normal. A bowel movement log was checked, which lists the last stool was 3 days ago. A equals assessment and is where the physician takes all the information and puts together their assessment of the situation and lists the working diagnoses. In this example, we have an 87-year-old male with chronic renal insufficiency, dementia, and hypothyroidism with new onset abdominal pain with the differential diagnosis of obstipation versus diverticulitis versus chronic constipation. P equals plan, which is where the physician identifies what they plan to do next. In this case, the physician plans a CAT CT scan with and without contrast, NPO, which means nothing per orum, which means nothing by mouth, and will follow up in the morning. The physician must sign the note. Physician orders is the section of the chart where the doctor writes instructions to any support personnel for any service that is to be done for the patient. This can be for any medication, laboratory test, or radiographic imaging, speech, physical, or occupational therapy, activity level, etc. The list can go on, but literally everything that is done for a patient originates from a physician order. In this example, we have CT for CAT scan of the abdomen and pelvis with and without intravenous contrast, diet, nothing by mouth except medications and clear liquids, orders to nursing to turn the patient every 2 hours and to record all inputs and outputs, I's and O's, and to guaiac test any stool, which tests for microscopic blood in the stool. The nurses' notes section is where the nurses record their notes. It reports any items of note which happened on their shift with that patient. If there is nothing to report, then the notes are scant, but if there are things happening with the patient, here's where you can find some details. In this example, the nurse's notes identify the patient was seen at the beginning of the shift, resting without complaints. At 12:25, the patient vomited, and the vomitus was green with chunks. Again, sorry for the graphic example, but this, realistically, is the type of information you may see. You may ask why the colorful description, and the reason for that is it gives physicians a clue about where in the gastrointestinal system there may be an issue. At 13:10, the patient complained of left lower quadrant pain. At 14:25, the patient complained of 4 out of 10 pain. That is a pain scale with 10 being the worst pain of your life. And at 14:30, the patient was given Tylenol. At 1600, the patient was vomiting clear liquid. At 1620, the doctor was paged. Laboratory results are reported in the labs section. These are the results of the lab test ordered by the physician. Blood chemistries, urine cultures, sputum cultures, feces tests, and any other laboratory test ordered by the physician have the results reported here. In our example, the test on the stool for microscopic blood, the guaiac test, was positive for blood on 3 separate occasions. Imaging is the tab where you can find the report of any imaging study, such as X-rays, CAT scans, MRIs, or others. In our example, we have the results of the CT scan of the abdomen and pelvis, reported as dilated loops of bowel to the sigmoid colon, inflammation noted throughout the bowel, several diverticuloses noted, no free air. The therapies, such as physical therapy, occupational therapy, and speech therapy, can get their own individual tabs or sometimes be combined in one area. In this example, PT, or physical therapy, reports the patient was unable to transfer from bed to the wheelchair secondary to pain, so PT was not performed. Another entry might look like PT, physical therapy, out of bed 3 times with hallway walking. Occupational therapy, OT, able to accomplish activities of daily living with minimal assistance. Speech therapy, patient with aphasia improving with tongue exercises. Case management is the area of the chart where the overall disposition of the patient is documented. For example, will the person stay in the facility, or are they expected to transfer to another facility? And if so, which one, and when is the transfer expected? There are also a couple other pieces of information which may be helpful that are not listed in the chart. One is the Medication Administration Record, the MAR. The MAR lists all medications given to an individual patient. It records the medication by name, the amount given, and when it was given. The MAR is usually found in or near the medication room. Sometimes there is a medication nurse for each wing of the building, and the MAR is found on his or her medication cart. There's also usually a BM log, and just like its name implies, it is a record of the bowel movements. No kidding, this is important, especially to older people. There have been cases of people not moving their bowels for 1 or 2 weeks, and as you may suspect, bad things can happen from a medical standpoint in those situations. Sometimes the BMs will be recorded in the individual's chart, but sometimes the BM log is in a hallway or assigned to a particular nurse, LVN, or CNA. Social services and activity director notes may be in the individual's chart, but may also be in a separate folder. They will give you an idea of what activities the individual is participating or not participating in. Because every facility can be different on where information is located, then if you cannot find the information you are looking for, ask for it. If the person you ask cannot help you, then ask the charge nurse. This is the person assigned as in charge of the nurses for that shift. What do you do if you are really stuck? Call a colleague or call the Ombudsman office. We are all here to help. And let me mention that if you have ideas or suggestions of how we can improve, that we are very interested in your ideas. On that note, I would like your feedback on this presentation. So please forward your comments to the Ombudsman office. Thanks so much, and bye for now.
Thank you, Dr. Schindler-Trachta. This training can't make you an instant expert on clinical records, nor is that your role. The record, or its contents, is one source for information as you investigate a complaint or respond to an inquiry. You can also get good information by consulting with a professional rather than reviewing a record. As Ombudsman, we must not make medical assumptions, interpretations, or provide medical advice. Our advocacy efforts will center around asking good questions and staying grounded in resident rights. In every case that a record needs to be accessed, follow our Ombudsman procedures. When a resident requests you look at his record, you may assist immediately and involve the resident in the request to facility staff. If you are the requester, consult with the staff ombudsman before proceeding. Always document that consent was given by the resident or the resident's representative, and provide that documentation to your Ombudsman office. For more information on our procedures for access, contact your managing local ombudsman. I want to thank you again for all you do on behalf of residents in long-term care. Keep up the great work. Stay in close contact with your Ombudsman staff, and continue to be the voice of common sense and resident rights. Thank you.